Hi, and welcome to the McGregor Dementia Support Ministry Podcast, a podcast providing relevant resources to those currently walking the dementia journey with their loved ones. Today's podcast is a session that was recorded from our Alzheimer's and Dementia Seminar held here at McGregor Baptist Church on February 22nd, 2025. Today's podcast is titled, Not All Dementias Are Created Equal, and it's presented by Dr. Edward Shaw.
Well, good morning. It's great to be back here. I missed last year, but was here the year before. And remember, one of the times I was here was the few weeks before the pandemic. So that was definitely a memorable time. But it's great to be here. I think the ministry that this church has, as Dr. Mass said, is really an amazing ministry. It's a world-class ministry that you have what you have here. So I want to share my story. As Pastor Mark said, I lost my first wife, Rebecca, from early onset Alzheimer's disease. This is a picture of our family in 2012. There's Rebecca and I on the left. We have 3 adult daughters. At that time, had 1 son-in-law and 1 grandson. That little squirt right there in my daughter's arms is now over 6 feet tall. But what you would never know looking at Rebecca is that she has middle stage Alzheimer's disease. So she needed my help getting dressed. In the morning, she needed help getting into her pajamas. She needed help taking her shower. She needed help cutting her meat so she could eat her food. And yet you look at her and she looks perfectly healthy. She was the person who shouldn't get Alzheimer's disease. So she was young. She had no family history. She was a swimmer. She was a very sort of intelligent, active, vibrant person. And so at the time, I was in my first career. I was a brain cancer doctor. And my research area, ever since medical school, was in cognitive function in cancer patients and cancer survivors. And so when Rebecca said to me at the age of 52, I can't remember anymore. Like, I read things and they don't stick. I knew that wasn't normal. And we got an opinion and a second opinion and a third opinion. It was before all the things that Dr. Mass mentioned were available for diagnosis, and she was eventually diagnosed with Alzheimer's disease. And she lived 9 years. She passed away 9 years ago. So that's my story. I want to show you a picture of this fellow right here. His name is Jim, and Jim is someone who also has Alzheimer's disease. A little more typical later in life onset, came from a family of 4. He and 2 of his siblings actually had dementia and died of that disease. And at the time that Jim passed away from Alzheimer's, so did Rebecca. And the reason I say our story is that Jim's wife, her name is Claire, and now Claire and I are married. And Claire, if you would stand up. And she's also the book story lady. I knew of Jim and Claire's journey before Jim passed away, and so after we lost both our spouses, we got together and we talked about grief over coffee. So after the 3rd coffee, Claire said, "I'm willing to talk about grief with you again, but it has to be over dinner." Right? And then she asked me to marry her, and what was I supposed to say? So I wound up changing my career from medicine to mental health. So I trained in dementia diagnosis and treatment, worked in our dementia diagnosis clinic at Wake Forest University, where I practiced in both of my fields for 25 years, and then began working more with a mental health focus, and opened a counseling center for families on the dementia journey called the Memory Counseling Program. We do individual, couple, and family counseling for people on the journey, and we do a lot of support groups. So that was like a big transition. So I'm going to have a little overlap with Dr. Mass, but I think that's okay. Good to reinforce things. So what is dementia? So dementia is the most common of the so-called neurodegenerative diseases. So you heard Dr. Mass say, well, dementia is not a disease. I guess what I'd say is dementia maybe will blend what you said and what I say. Dementia is not a diagnosis. Like if you say someone has dementia, it doesn't really tell you anything specific. Dementia is really a term that refers to a family of diseases, and that's what we're going to talk more about. So it's a neurodegenerative disease, meaning the brain gets sick in some way, it becomes inflamed or irritated, and the consequence of that in Alzheimer's disease is the amyloid and the tau that Dr. Mass shared with you. And there are other neurodegenerative diseases in that family, like Parkinson's disease, you've all heard of that, Lou Gehrig's disease or ALS, you've heard of that. They're all in this family of neurodegenerative diseases, and they affect the brain and body in different ways. Dementia specifically causes two things. So if you're going to diagnose dementia in a person, they have to have two things happen. One is they have to have some problem with their cognitive function. So we'll talk on the next slide about what is cognitive function. It's basically your thinking functions. And then that cognitive function change has to cause the person to become more dependent. Like I shared with you with Rebecca, she needed help getting dressed. She needed help cutting the food on her plate. She needed help taking a shower. That's functional dependence. She used to do all that stuff, of course, on her own. And then she had to depend on me as her primary caregiver to do it. So cognitive function loss and functional dependence. That's the two things we look for when we evaluate someone who comes to our clinic and says, well, I'm having trouble with my memory or something else. So the most common type of dementia is Alzheimer's disease. So that is a disease or a diagnosis, Alzheimer's. So we're going to talk about sort of the common dementias in just a minute. But let's talk about what cognitive function is. So cognitive function, the word cognitive just means thinking. And so the way our brains have been created, so here's a picture of a brain right there. Your brain doesn't have colored lobes, by the way. It's kind of a boring grayish brown color on the surface. But for the purposes of illustration, we can map the functions of the brain to certain lobes or parts of the brain. So our brain, our thinking functions, our cognitive functions, there are 5 main ones. The first one is paying attention. We call attention the gateway of the brain. If you're not paying attention, then it doesn't matter what somebody is saying. So if you were right now sitting there and you were on your phone reading the news and not paying attention to me, then you wouldn't really hear what I had to say. So when somebody is disattentive, like you've heard the diagnosis ADHD, attention deficit hyperactivity disorder, kids who are disattentive in school and they get squirmy and wiggly, and they don't learn because they're not paying attention to the teacher. Now, I would say for the most part, most types of dementia early on are not disorders of attention. Attention is okay until later. The next thing our brain does, the second thing, is planning, problem solving, multitasking, and then having judgment and insight. We call this executive function. Not executive like the executive of a company, but executive function like I have to execute a series of steps in order to accomplish a task. Like cooking, for instance, following a recipe. The most complicated multitasking thing we do is driving. So there was a paper published in an occupational therapy journal. If you decide I'm going to go to CVS and pick up a prescription, there's like 40 steps involved. all the way from having the thought, I need to go, to getting the keys and getting in the car, opening the door, getting in the car, starting the car, so on and so forth. Multitasking is part of all the complex activities we do in a day, and it's one of the main cognitive functions. The third cognitive function is memory. So like when you hear the term Alzheimer's, you think about, well, it's people who have poor short-term memory, and that's true. Memory loss is the first symptom of Alzheimer's, and it's the worst symptom of Alzheimer's. We say it's first and worst. And memory is actually a super complicated function. We could have Dr. Mass give us probably a whole morning on just the different kinds of memory. But in fact, for our purposes, we think about short-term memory, we think about long-term memory, and those are important because if you're going to learn new information, like if you're going to learn new information, you have to remember it, right? And so learning and memory are very linked to each other. And that was actually Rebecca's first symptom. She would read things, but she couldn't remember them. They didn't stick anymore. That was her first symptom. The fourth cognitive function is language, both understanding what somebody says, like you're doing now, or expressing yourself with words or in writing. That's called expressive language. And so that's sort of number 4. And the last one is maybe a little bit harder to understand or harder to explain. It's called visual spatial skills or visuospatial function. It goes by different names. But it's this ability to understand where your body is in 3-dimensional space. So if I close my eyes and I go like that, I know I'm on a stage higher than you and my right arm is out from my body. I don't have to really think about it. I just know it automatically. And we use this all the time, like in driving, for instance. You drive down the middle of the lane, you know not to, go off to the middle line or the line on the right. When you come to a stop sign or a stop light, you have to slow down before, although in Florida, I don't know how well that really happens. I'm going to talk about that this afternoon, by the way. So, but your depth and distance perception, kind of your orientation, like knowing the day, the date, the time, getting from point A to point B, your wayfinding abilities, and even just understanding what an object is. This thing in my hand is the slide advancer. And object recognition. This is all part of spatial function. And so paying attention, multitasking, remembering, speaking, and spatial skills. Those are the 5 cognitive functions. So when Dr. Mass talked earlier about, if you have dementia, you have a cognitive function issue, you would go to someone like him or Dr. Silver's going to talk after me, like her, and they're going to assess all of these cognitive functions. Now, there are 2 things that are related to cognitive function that do change with dementia, but they're not strictly speaking cognitive functions. They're personality and it's mood and emotions. And people who have dementia, they often have personality changes. Or they may have changes in their mood. So they may have more depressive symptoms or anxious symptoms that comes from their cognitive functions not working properly. So we always evaluate those things. And you heard Lee say just a few minutes ago that, make sure you get your mood evaluated because one of the most common causes of reversible memory loss is depression. So it's important when you do a cognitive function assessment that you also have some understanding of whether personality has changed or mood and emotions have changed. So I talked about this multitasking ability, and when we in the field kind of measure the ability of a person to multitask, we assess what are called their ability to do their instrumental activities of daily living. So that includes things like cooking, driving, managing household finances, doing housework, managing medications, getting all the pills in the pill holder, making a grocery list and going grocery shopping. And as you heard Lee talk about, working with that cell phone, right? Trying to figure out what the iPhone does. I might have to take a few lessons from you on that. So those are the more complicated activities of daily living. And those are affected earlier on in someone who is on their dementia journey. Later on, their basic activities of daily living are affected. Bathing or showering, continence, urinary incontinence can be affected first, or just normal toileting hygiene, getting dressed, being able to eat a meal, coordinate the movement of the knife and the fork together to get food in the mouth, even just getting up and down from bed or a chair and just walking safely. Part of that spatial function challenge is if you don't know that sort of going up a flight of stairs, that the stairs are 9 inches high, we take that for granted. But if all of a sudden you don't register that height, or that those stairs look flat, right? Then going up and down a flight of stairs or up and down a curb becomes more difficult. That's why people fall who have dementia, because their spatial function is impaired. So Dr. Mast, I stole this slide from your presentation, but he showed you the slide earlier. And so someone who's functionally capable, their brain is plump and healthy, like you see that half on your left. But on the right, the brain has shrunk by like 30%. And you see towards the bottom, there's like an empty space that looks like a little fish. That's the memory part of the brain. So it's not that when people with dementia, when they can't do something like remember, and they ask the same question over and over again, they're not asking repetitive questions to bug you as their family member or caregiver. For them, it's a new question every time. It's not that they won't remember, they can't. Like that part of the brain is gone. And when the brain shrinks and all those neurons are affected, that is what translates into the functional loss. So as you go from what's called mild cognitive impairment, which is where maybe you have some memory loss, but you're functioning pretty normally, all the way through the stages of dementia, you lose these different functions that are shown here. Now, this slide, I just want to point out that the proportion of our population that's 65 to 75 is the purple bar at the top, and you can see that's getting fatter over time. We are getting older, right? So I'm sort of in the middle of the baby boomers, but all the time there's more and more baby boomers. Right now, we have about 7 million people in the US that have Alzheimer's disease. But by 2050, so another generation's time, it's going to almost double. And so, yes, we have had a pandemic of COVID. We are in an epidemic of Alzheimer's disease and other forms of dementia because of our aging population. So if you look at the risk factors for dementia, the most common one is age. The older you are, the more likely you are to develop dementia. But I will say that of the 211 people in the room, the lifetime risk of getting dementia is about 1 in 8. So most of you are not going to get dementia. So if you can't remember names of things, that's absolutely normal for cognitive aging. So I went to an aging conference a few years ago, and they had different vendors like on their main street. There was one vendor that had this huge long line, and it was a t-shirt vendor. And I thought, why would that t-shirt vendor be so busy? They were selling t-shirts that said, "I can't remember your name either." So Kim, if you want to raise money for speakers, maybe get those t-shirts. So I'll just run down the risk factors. The older you are, the more likely you are to develop dementia. Women are more likely than men. People who are brown or black are more likely than people who are white-skinned. If you have a family history in either a sibling or a parent, you're more likely to develop dementia. If you have high blood pressure or diabetes, you're more likely to develop dementia. If you've had a head injury, The list goes on and on. It's a long list. In the last year, there have been a couple of research studies saying if you have poor dental health, gum disease, or lots of cavities, that you're at higher risk for developing dementia. Because one of the theories is that maybe some of the germs that live in and on us can get in our brain and cause dementia. But the truth is that we really don't know what causes the inflammation of the brain and what Dr. Mast had referred to as like this accelerated aging process of the brain. I'm going to mention, because Kim had asked about this, there's some who called dementia type 3 diabetes of the brain. That the problem is energy utilization or sugar utilization in the brain. And that is one of the theories of maybe for some people that have Alzheimer's disease. And at Wake Forest University, where I used to work, we actually had clinical trials where people inhaled insulin through their nose that would go up into their brain. Unfortunately, that hasn't really panned out as being effective, at least yet, but that's one of the theories that's out there. So let's talk about what are the most common types of dementia. So the way I think about the term dementia is it's like an umbrella term. So an umbrella term in the sense that dementia is a family of diseases, and it's like if I asked you, what do you drive? What kind of car do you have? You would tell me the make and the model and the trim level and the color. And that's kind of the way it is with dementia. All dementias are not created equal. So under the umbrella term of dementia, Alzheimer's disease is the most common. And then there's Lewy body dementia, vascular dementia, what's called frontotemporal dementia, and then the dementia associated with Parkinson's disease. So Alzheimer's disease is most common, and then there's a variant that I'm not going to memorize, although where's my friend Larry? There he is, right there. Larry, I want you to memorize that second term if you would, because I'll be testing you on it. So Alzheimer's disease is most common. Next most common is vascular dementia. That's post-stroke dementia, or someone who's had a bunch of TIAs, transient ischemic attacks. It's because there's not enough blood getting to the brain, and then the person develops cognitive impairment. So that's sort of next most common, and you can have combinations of those. You can have both vascular dementia and Alzheimer's disease together. Lewy body dementia is different. It's related to the dementia of Parkinson's disease. And it really is just a matter of if the cognitive issues come first, then we call it Lewy body dementia. If the Parkinson's disease symptoms come first and then the cognitive issues follow, then we call it more Parkinson's disease dementia. Not everyone who has Parkinson's disease will develop dementia, by the way. It's maybe a third to a half, depending on which research report you read. Then a little bit less common is frontotemporal dementia. So the front lobes of the brain, this is highly scientific, are called the frontal lobes. The side lobes of the brain are under your temples. They're called the temporal lobes, right? So easy to remember. And when you have a dementia that affects the front and side lobes of the brain, we call that frontotemporal dementia. And that looks really different than Alzheimer's disease or Lewy body or Parkinson's dementia. You may have heard about Bruce Willis has been in the news. He has a subtype of frontotemporal dementia called primary progressive aphasia. It's where the person loses the ability to talk or understand what people say to them. And it often then will evolve into Alzheimer's or the other type of frontotemporal dementia that I'll describe, called behavior variant FTD. And then there's like 40 other causes of dementia. So there are many, many causes, but those first four there, Alzheimer's, vascular, Lewy body, frontotemporal, that makes up 99% of the types of dementia. So I'm going to go through a series of 6 slides now and talk about what are the symptoms of each type of dementia and what are some of the caregiving challenges that are part of that. So with Alzheimer's disease, the big 3 symptoms are short-term memory loss, difficulty with that multitasking ability, the planning, problem solving, multitasking, judgment, and insight, which, by the way, often can take the form of the person being scammed. I hear this in my office all the time. The person becomes trusting of online people who are out to get them. And they sort of share personal information they shouldn't. It's because of that loss of judgment and insight. So memory loss, multitasking challenges, and then the spatial challenges. The person starts to have falls, or they have fender benders. They scrape the side of their car on the curb, or they get lost when they're driving. Or maybe they get disoriented in the sense, like we keep track of, you knew that today, Saturday, conference was happening. You kind of lose track of what your schedule is, your orientation to your day and your week and the month and the season. So there's some disorientation. So if someone comes into our clinic and they have short-term memory loss, and they have trouble with their multitasking ability, and they have spatial challenges that Dr. Mast or Dr. Silver finds those things, and their amyloid blood test that Dr. Mast referred to is elevated, that person almost certainly has Alzheimer's disease. But if someone is cognitively normal, they're not having any of those symptoms, and their amyloid blood test is elevated, that's the conundrum. And Dr. Mast introduced that, and Dr. Silver, I hope you're going to talk about that just a little bit. So those are the big three symptoms of Alzheimer's disease. Vascular dementia can look very similar to Alzheimer's, but usually the person has had a stroke, and they have some consequence of their stroke. Might be some weakness or paralysis on one side of the body, could be in their face or their arm, could be speech issues, it could be visual impairment, so they have the cognitive issues, plus they have the symptoms of their stroke. And that's what makes vascular dementia a little bit different. So now we're gonna look at the common sort of behavioral challenges and caregiving challenges that occur in people with Alzheimer's disease. So I was talking to somebody before the conference started, and she was describing this first thing, which is apathy. Apathy is just sort of a fancy term for lack of motivation, lack of get up and go. This is a really common symptom, not just in Alzheimer's, can be in any form of dementia. So Dr. Mast was saying, well, exercise is so important from a lifestyle factor, but how do you encourage someone to exercise when they want to be a couch potato? Because they have apathy, they don't have motivation. And so that's part of what caregivers, need to try and do, is motivate their loved one to get up and have some movement. So apathy is a challenge. I already mentioned the poor insight. Sometimes the poor insight is an issue with, well, there's nothing wrong with my memory. My memory is fine. Why are you taking me to the doctor? I remember just fine. Have any of you had that situation with the loved one? Oh yeah, hands going up all over, right? Because part of what your brain does is it gives you insight, understanding into what your symptoms are. But if you lack the insight, right, you're gonna feel like you're being dragged to the doctor. And so that can be really a caregiving challenge. I already talked about repetitive questions or repetitive vocalizations. And that's where people say the same things over and over. And they do it because they forget they've said them before, or sometimes for people living with dementia, it's very soothing to say the same things over and over. Paranoia is another common caregiving challenge. It can be paranoia about money. People who have Alzheimer's disease that can occur in other forms of dementia get paranoid about their money. They feel like someone is stealing their money or stealing their stuff. So they start hiding money all around the house, or they hide their jewelry. Problem is they can't remember where they hid it. So that creates a problem. Or one of the most difficult counseling challenges that I see in caregivers, where their loved one accuses them of unfaithfulness, of infidelity. And this can be a really hurtful kind of paranoia that somebody with dementia can have. Agitation, The late in the day agitation we call sundowning can be a real caregiving challenge. And then people who have dementia often will have a visual misperception. So I'm going to use this as an example. They'll see a cord like this and they'll think it's a snake. Whereas somebody with Lewy body dementia, as I'll talk about in a second, they actually have hallucinations. They see snakes when there aren't any visual cues for it. It's truly, they see things that aren't there. So that's Alzheimer's disease. And then I think one of the most common challenges, and I'll describe this with our family, is lost identity, where the person doesn't recognize their loved one, their spouse or their adult kids or their family members or friends. And this is really, it's a painful loss that happens. Now, Lewy body dementia is really different than Alzheimer's disease. Lewy body dementia, the most prominent symptoms are delusions and hallucinations, and the hallucinations are often very frightening. The person believes that people are out there trying to get them, to hurt them. And the person can also have nightmares, terrible nightmares, or they can have what's called REM sleep disorder, where they thrash about in their sleep. And I've had spouses whose loved one has REM sleep disorder, and they get punched or kicked. You know, they get physically injured and they can't sleep with their spouse anymore because of how aggressive their sleep disturbance is. So these are more like psychiatric symptoms, the delusions and hallucinations. That's what you would see like in someone who has schizophrenia. But when you see these, schizophrenia, the average age of diagnosis is late teens to early 20s. So if you see new onset delusions and hallucinations in someone who's in their 70s, it's probably more likely Lewy body dementia than it would be schizophrenia. Lewy body dementia looks like Parkinson's disease. The person has a slow shuffling gait. They look down while they're walking. Their feet kind of stick to the floor. We call that a magnetic gait. Their face looks like it's sort of stiff or paralyzed, almost like a mask. And so that's part of Lewy body dementia or Parkinson's disease dementia. And then they have trouble with some body functions. We call them autonomic functions. I call them automatic functions. It's all the sort of rhythms and cycles that you have in your body. Blood pressure, breathing rate, heart rate, temperature regulation, even affects your continence, keeping your sphincters closed when you don't want them to be open. And all these automatic body functions are also affected in people with Lewy body dementia. So you can see this is a very different picture than is Alzheimer's disease. In fact, the person with Lewy body dementia may have perfectly normal memory. So the cognitive function loss is much more variable in Lewy body dementia. So the caregiving challenges are related to these symptoms, dealing with somebody who sees things that aren't really there. So they can be visual hallucinations, they can be auditory hallucinations. For some reason, people who have Lewy body dementia will often describe a group of children singing to them. Like it's a common kind of visual and auditory hallucination. They tend not to sleep very well because of the nightmares and the REM sleep disturbance. And they have a lot of day-to-day variability, or even minute-to-minute or hour-to-hour variability. 1 hour, they may be great. You'd never know they had anything wrong. And the next hour, they may be flattened out in bed, muscle stiffness and having some confusion. It can be quite variable. And then if the Parkinson's symptoms are prominent or these automatic functions are not functioning normally, the caregiving can be very demanding. If the person so those of you who have a loved one with Parkinson's disease, you know that if the person has difficulty with mobility or they're bedbound or chairbound, that's a whole different level of caregiving, as is incontinence. So, and that's often like the game changer caregiving issue, is when the person becomes incontinent, when the caregiver has to become, I always use the phrase, the rear admiral. right? But for example, in our family, my 3 adult daughters, who all were very involved in the care of their mother, they drew that line in the sand. They said, Dad, we are not going to do continence care for Mom. We're just, for her dignity, we're not going to do that. And that's often when people need more help. So let's transition to frontotemporal dementia. And Kim, how many more minutes do I have? 3? Oh, 10. Oh, good.
No, he said 8.
8, okay. Yeah. So one of the things I've learned, I'm going to snitch on Kim right now, but when you get within like 3 minutes of the end of your talk, and then I don't pay attention to the timer. I know I should, but I really don't. But then I see Kim, and then she gets the look. Okay. The first part is the stare, yeah? Okay. But then if you get within 1 minute, then you get the look, right? And I don't want that. Like, that would be psychologically traumatic. So, okay, so let's go on. And we've talked about Alzheimer's disease. We've talked about vascular dementia. They can look sort of similar. Then this very different picture of Lewy body dementia. Now we have a third very different picture, and that is what we call behavior variant frontotemporal dementia. So these front lobes of your brain, one of their functions is they monitor what you think and what you say and what you do and what you feel. And so sometimes when you get one of these crazy Florida drivers, I call them the weavers, you know, they're going in and out about 50 miles over the speed limit. And you might say something under your breath or in your head that you normally wouldn't say out loud, right? Could be like a 4-letter word, or it could even be a longer one, you know, whatever. But in other words, we are used to applying social filters to what we say and what we do. But the big characteristic of frontotemporal dementia, the behavior variant form, which is by far the most common, the person has a dramatic change in their personality. So I had one woman whose husband inappropriately touched the 16-year-old granddaughter, right? Something he never would have done. And so people say things and they do things without any social filters. So that's one of the big characteristics. And the other characteristic, kind of a unique one that we look for, it's a loss of empathy. Like, you know, empathy is understanding what another person is going through when they're going through difficult times. And the person loses their empathy. The spouse will say, it's like he just doesn't care or appreciate, you know, about me or anything going on in my life anymore. So that looks really different than memory loss or these delusions and hallucinations. The second thing is with frontotemporal dementia, the temporal lobes, they're responsible for memory, but also for language function. So basically, they sit underneath your ears from your temples here to behind your ears. So it makes sense they'd be involved in language. And the person will have trouble getting their words out. Or I have one fellow with this who, you know, you can speak to him and you think he has a hearing loss. His hearing is fine. It's just the words come in garbled. They don't process properly. So that is his major issue right now, with some of the personality change. And then the person with behavior variant frontotemporal dementia, they have variable difficulties with their executive function, the planning, problem solving, multitasking, and insight. But the big thing is the personality change. Now, the symptoms that can be caregiving challenges for people with frontotemporal dementia, well, the personality changes can be difficult. Because you can imagine the woman whose husband is inappropriately touching young women, that would be difficult to go to a family gathering when there's grandchildren there, granddaughters there. Or it would be difficult to go out in public. So that's a caregiving challenge. Also, people who have frontotemporal dementia, they can have outbursts. You occasionally see this in vascular dementia, but it's pretty characteristic of frontotemporal dementia. It may be an outburst of crying, or it may be an outburst of laughing. And that's not unusual if there's something to cry or laugh about, but it's more or less spontaneous. And so, or it could be, so I have a number of people I've counseled where they'll say, you know, she never swore. I never heard her swear once in her whole life. And all of a sudden, she's cussing like a sailor. And that's the loss of that social filter that's so typical of frontotemporal dementia. Other things, they can have obsessive or compulsive behaviors, and then they tend to binge eat carbohydrates like sweets or potato chips or things like that. So those are some things that we look for. I want to just say 3 more things in my last 5 minutes and 41 seconds. I like to harass Kim too. 3 minutes, she says?
That one's wrong.
Oh, that one's wrong.
You never look at it, you said. So you have now.
Oh, I see. She said that timer doesn't work. So now she's setting the timer wrong to even confuse me more. So just 3 more things. For all types of dementia, people who have dementia, because their brain is inflamed, it has to work harder and it uses more energy and it tries harder. So they're tired a lot. The same person I was talking to said, my mom could sleep 23 hours a day. People who have dementia, they sleep a lot more than people who don't have dementia. They're more prone to depression, anxiety, the things like the agitation and the sundowning. And weight gain is often common earlier in the disease, and weight loss is pretty typical later in the disease. But the more advanced the stage of dementia, once you get into the late stage, all forms of dementia really kind of look the same. All the symptoms blend together. And then even though I differentiated those different types for you, by the end, you see all those symptoms in most people with very late stage dementia. So in the late stage of dementia, the physical burden of caregiving increases because you need to do more and more for that person as they're able to do less and less. And the emotional burden of caregiving increases. Not just because you're losing someone who you love in little pieces over a long period of time, but that person becomes less reciprocal in your emotional love bonds, in your emotional love relationship. That's actually the theme of the book, Keeping Love Alive as Memory Fades, is the person can't express their emotion like they used to. They can receive emotion, you can give them your love, but they just won't say the I love you back necessarily, or they won't do the hugs, or just the ways they used to show their love for you. Those things change. So, I think I'm going to, in the interest of time, I'm going to skip through those. I will say that I introduce you to Claire. She actually is the bookstore lady. So I'll just want to tell you about several of my books and a couple others we have at the bookstore. The Dementia Care Partners Workbook I wrote after Rebecca passed away because I wanted to sort of provide everything from diagnosis in the brain function through caregiving challenges to end-of-life considerations, sort of everything you might use as a caregiver when you're partnering with a loved one with dementia. And then there's space for journaling. That's the Dementia Care Partners Workbook. Keeping Love Alive as Memory Fades. I know you've had Dr. Gary Chapman, the five love language guy here at this church. We co-authored that book together with a woman named Debbie Barr. And that book is about the emotional toil of caregiving. Talks about our family story and the emotional toil and just how it is you can use the 5 love languages as a simple toolkit to maintain those emotional love bonds. Debbie Barr wrote a devotional that goes with our Keeping Love Alive book called Grace for the Unexpected Journey. It's an amazing devotional, and we provide that. And then some people like the 5 love language book. So with that, I'm going to stop. Kim has now given me the look.
Thank you for listening to this podcast. Please subscribe to the channel if you've not already done so, and leave a review if you found this content to be helpful.